Again, thank you. Welcome to our webinar today on community health workers' impact on violence prevention. So my name is Mongshi Kang. I am the Envision CHW training coordinator, and I will be your lead facilitator for today's webinar. While on call today, we do have a small list of operating agreements to ensure that we can collectively build a welcoming and brave space. Much of today's webinar will be delivery content, so we do ask for you to stay on mute and pose questions in the chat box. The chat will function as your primary point of connection today. We encourage you to use it frequently and treat fellow attendees with dignity and respect while doing so. And then one last kind reminder to do what you need to do to take care of yourself. So today I will start off by sharing some Envision news, including our new platform that we just launched. And then we will go into objectives of our presentation, and then also go into our 3 presentations that we have for today, and then we'll wrap it up. So Envision News, have you all joined our platform, our community platform called My Envision? It is an online community space for CHWs and CHW allies and our 2109 CCR recipients. So if y'all haven't joined it yet, please check it out, and a link will be dropped down below for the folks who haven't to come and join our platform. So who is Envision? Envision is composed of community health workers and community health worker allies who work together with financial and administrative support from the CDC to elevate roles of CHWs in COVID response and recovery. So that's who we are. Oh, so I'm told can you all hear me? Well, okay, so let me try to speak. Yeah, I'll try to. Okay, let me try to speak a little bit louder. So I heard that there's some audio issues. Okay, so thank you, Elizabeth. So that's who Envision is, and then we do have our listserv link in our website below too. And if you are interested in learning about who we are, or please join our listserv in our website, and you can also come onto our website and comment, make comments on our website as well. So links for all of these will be dropped down below. So with that, it is my pleasure to transition into our primary content today, and I will be introducing our first presenter, who is from the CDC's Division of Violence and Prevention. So Candace Girard, who is a senior advisor for health equity in the Division of Violence Prevention, and Joy Bradford, who is the public health advisor and project officer on the surveillance branch violence surveillance coordination team. So I'll pass it on to the 2 of you.
Thank you so much, Hongji, and hello, everyone. As previously stated, my name is Joy Bradford, and I'm so ecstatic to get a chance to talk to you all about the importance of CHWs and their contributions with violence prevention efforts. I am going to pass it to my colleague, who will get us started for today's webinar.
Great, thanks, Joy. Can you go to the next slide? Okay, so again, we'll be presenting on the spotlight to promote community health worker leadership in violence prevention. Next slide. Like we said, I will be presenting along with my colleague Joy. Next slide. So why are we interested in community health worker involvement in violence prevention? First, as you know, violence and inequities and risk for violence are serious public health issues with lasting impact on health and wellness in the US. This is currently a national focus, and we currently address community violence, structural racism, and health inequities. Community health workers, often women and elders, have appeared repeatedly throughout history as those who heal others and help communities thrive. It's impossible to describe the centuries of community health worker contributions in this presentation, but we would like to share a few. We have, please go to the next slide. We've had so much great support for this work from CDC staff and the field, and would like to recognize everyone here in alphabetical order. These and many other individuals are leaders in the field who have participated as co-authors and reviewers of the manuscript, listening sessions, as well as training sessions. Next slide, please. In today's training, we'll provide you with a quick introduction and overview of the community health worker profession. Then we'll talk with you about violence prevention efforts that align with DVP's evidence-informed violence prevention strategies. And we'll discuss current efforts to uplift CHW contributions and opportunities to support the work with CHW professionals and allies. Next slide. For nearly 40 years, CDC's Division of Violence Prevention has utilized and shared the best available data and conducted research to identify what works to prevent various forms of violence. We want to emphasize that violence is preventable. We bring together partners and connect data, science, and action to inform development, implementation, and sustainability of violence prevention strategies proven to be effective. Our work is on primary prevention and has a basis in the best available science. We use integrative leadership approaches as well. Please go to the next slide. Violence has lasting impacts on health and life opportunities. Injuries are outcomes that people typically think about, but experiences of violence are strongly associated with a range of mental health problems, maternal and child health consequences, infectious diseases such as HIV and STDs, a range of chronic diseases, including cancer, diabetes, and heart disease, as well as negative coping and high-risk behaviors, all of which contribute to lifelong ill health and early mortality. They also have lasting impacts on opportunities affecting educational achievement, occupational attainment, and earnings, impacts that can reverberate across generations. Next slide, please. An important point is that violence is a direct result of access to social determinants of health, like income and housing. For example, violence has been shown to affect mental health and chronic diseases. As many of you know, health-related social needs assessments and referral systems are addressing interpersonal violence. Preventing violence by addressing social and environmental conditions could also have wide-reaching impacts on health and well-being in communities. Next slide. So our ultimate goal is peace. That means that we're not focusing just on the absence of violence, but we want to look further than that and understand beyond that. That means all of us, CHWs included, are part of DVP's vision to create a violence-free society in which all people and all communities are safe, healthy, and thriving. Next slide, please. So we'd like to hear from you now and understand which of the following topics related to violence prevention align with your work. Please let us know. I think there's going to be a poll, yeah. So there's only one choice. So pick the one that you work with the most. Thanks so much. And I'll leave it to Joy to present the findings.
Okay, Well, there is definitely a lot of people in the chat. I mean, even though we're not able to make it as interactive as we would hope for this session, please feel free to also elaborate with your responses if there's any thoughts from the reflections on the connections of social determinants of health and violence. Because it's been about 2 minutes, I think we can launch the poll results and kind of see where people find that their work intersects. And so the most common answer is community outreach. However, we know that a lot of these different factors are interrelated, especially when we think about economic stability and educational access and quality. And so appreciate to see kind of the spread of how the different topics align with your current efforts. In the next slide, we talk about how violence is a serious public health issue. In 2020, more than 240,000 people were victims of homicides, and more than 1.4 million people were treated for hospital emergency departments for assault-related injuries. And so to help find answers to prevent violence, we need to know the facts. And so the CDC's National Violent Death Reporting System, known as NVDRS, tries to understand the who, when, where, and how on data with violent deaths and provide insights on potentially some of the circumstances. So NVDRS collects data from death certificates, coroner medical examiner reports, law enforcement reports, and toxicology reports into an anonymous database. And so you can see all of the different data elements on the screen that are captured and how this can help better understand the intersections with relationship problems, mental health conditions, and other life stressors. The number of violent deaths and injuries, as we know, are just part of the story. Many people survive from violence and have the permanent physical and emotional scars. Since violence erodes communities by reducing productivity, decreasing property value, and disrupting social services, it's imperative that we figure out ways that we can understand the burdens and work together to build safer communities. If you are interested in learning more about how data is specifically impacting your community, you can check the link that is found in the chat box for Whiskers. In the next slide, we discuss the intersections with resilience. Resilience can be seen in disasters that are large and small, where communities bind together to help clean up chemical spills, heal from shootings, or determine also how to build safer and healthier processes, leverages effects that improve population health and connect the individuals, systems, and communities. This means encouraging actions that build social cohesion and also aim to figure out ways to build positive social relationships, which we know are keys to resilience. Social supports are also an asset. So when we think about universal free healthcare, paid parental leave, and other opportunities to build safe, nurturing, and caring relationships, we know that these contribute to building a more resilient community and also connect to building health systems and connecting. Use deep experience in these efforts provides unique expertise that promote partnerships and fill in the gaps for community resources, which is why we are so excited to talk to you today. In the next slide, we discuss the intersections of the CHW roles. As you can see on the screen, there are common roles that are a core set of competencies and skills, which were developed and decided by CHWs starting in the 1990s. In a literature review conducted by the CDC and also other colleagues, some of whom are on the call, we understood that violence prevention activities also connect with these different core roles. Whether we're thinking about case management, looking through abilities to create direct services, or also participating in evaluation and research, all of these are unique roles that the CHWs complete to improve services for individuals and the community as whole. They can point to barriers about how policymakers can think through ideas and also understand structural deficiencies. Furthermore, CHWs have different titles and specializations, but unite under the same umbrella. And so when we think about accessing resources, training, and professional development, each of these avenues can also intersect with violence prevention efforts. And the next slide, we discuss how you can see the unique definitions of CHW roles, and apologies for my email, the unique intersections of community health workers' roles and how they are both credible messengers and also place-based, community-specific, multi-sector violence prevention work. Across programs, we have analyzed examples from hearing from the field about ways that CHWs have leadership, whether considering the different direct and indirect connections with violence prevention. And so you can see some of the different roles listed on leadership roles listed on this slide. The next slide then discusses the examples of the titles to help you make connections about the existing violence prevention programs. We have found that CHWs who are potential audiences for the CCR program are able to cast a wide variety of efforts. And so this is not an exhaustive list, but there are many other professionals like victim advocates who meet the definitions of CHWs and could want to pursue professionalism under the umbrella. Also, I wanted to note that CHWs also, such as violence interrupters, have different intersections that may or may not identify with the title of CHWs, but can still really connect and build safer communities. Finally, the next slide would be showing the current literature review that happened with collaboration with CHASM. And so when we're thinking about ways that CHWs have been found to work on public health programs, we know that this could be occurring with community violence, family violence, and also populations experiencing structural racism. So I appreciate everyone's patience in trying to get through a lot of information, but wanted to make sure that we were respectful of your time. And so just was giving you a few key highlights about how CHWs engage in violence prevention. And so if there's any questions, please feel free to put them in the chat box. But this was just a general overview of ways that we can see the intersections with CHWs and violence prevention. I'm going to now go to the final slide and pass it to my colleague Candace, who can talk about how violence prevention practices are intersected and understand your resources.
So can you skip a couple slides? So next slide and slide after that. So this spotlight is a document highlighting how CHWs serve as community resources supporting individuals, families, and communities in upstream drivers of violence. The primary audiences for this document are CHWs, but also entities, organizations, and allied individuals who are in a position to advance, support, and uplift CHWs in preventing violence and addressing the underlying determinants that impact violence. Next slide. So the working draft of the spotlight includes the following 4 sections. The first section includes information on the origins of CHWs in the United States and violence as a public health issue to bring in the historical context. The next section is a logic model, which we'll see more about in the next slide. And then the next section is about cross-sector collaborations with CHWs and examples in the form of success stories that highlight activities occurring in the field. Next slide. So our discussions about the spotlight will use this model to outline the link between CHW's individual work on the ground and structural change. CHWs work with individuals and families, helping them identify changes needed in the community. We want to support CHWs in working to develop and implement approaches that resonate with their communities and enhance the work they are already doing in order to decrease inequities in risk for violence. You might already be familiar with how CHWs have addressed the needs of people at greatest risk for violence. Community outreach programs and hospital community partnerships have brought in CHWs to assess individual needs, provide referrals to community resources, and offer mentorship to youth and peer support of adults. Through these strategies, CHWs can be involved with identifying environmental risk factors such as vacant lots and advocating for community-driven solutions. CHWs also have the capacity to contribute to research and evaluation. We believe all of these activities will contribute to an overall decrease in inequities and risk for violence and poor health. Now I'd like to hand it over to Joy to describe our success stories.
Thank you. So if possible, can we launch the next poll? So we have talked about the Spotlight, and this resource will be hosted on a variety of CDC platforms. And so we're interested to hear about how this would be used to inform your work, and also ways that you personally would enjoy seeing success stories of CHWs being shared. So please select the one that is most applicable to informing your work and where you get resources. I'm going to go ahead and launch the poll results. And so thank you for this information. It's very helpful to understand pathways to connect CHWs, as well as opportunities to uplift the success that's happening in the violence prevention field. We're going to go over 3 success stories that are currently being included in the violence prevention resource that's spotlighting work. And so the first effort comes from Drexel University, and they connect different youth with trainings that have been impacted by firearm violence and get opportunities to have employment pathways and partner with community and other stakeholders to ensure that youth receive wraparound services. In the next success story, we talk about the Interrupting Violence in Youth and Young Adults, which is a partnership with Grady. And on the screen, you can see the many faces across the sectors working on this effort, which is a cross collaboration between different staff. Also, Emory has found a host of success in partnership with the Grady Hospital program to ensure that youth can receive services, as well as understand nonprofit opportunities to speak about rights for victims of crime with compassion, dignity, and respect, and allows them to connect to various resources such as employment, education, and other important resources. The final example for the success stories is a Native American approach that is known as the Family Wellness Program. And under this initiative, different tribal leaders hold healing circles that have been Alaskan Native led and emphasize cultural and spiritual aspects in order to bring healing to the community. The tribal leaders also teach their peers and other youth about the importance of creating healing, nurturing relationships, and partnerships explain that they've been inspired to heal others and understand connections with violence. I'm going to pass out the next steps and the call for action to Candace, and then we will close out today's webinar. And thank you again for the depth of information being covered today.
So we have started working on a draft of this document, but we are currently inviting reviewers to provide feedback and insights. If you're interested, please feel free to email us to preview the document. The other key steps will be designing the spotlight to be visually appealing and ensuring information can be translated to Spanish to reach a wider audience. We also plan to continue to have convenings related to community health workers supporting violence. Thank you so much for your time, and we look forward to engaging further.
Will you go to the next slide, please? So thank you, everyone, and thank you, Joy and Candace, for your presentation. Next up, I would like to introduce our second presenter, whose name is Ramana Rabbani, and she is the co-founder of Community Healing through Activism and Strategic Mobilization, CHASM. And I will pass the mic over on to you, Ramana.
Thank you so much, Mangshi. Thank you, everyone. It's great to be here today. Can you see me on the screen, Mangshi? You can see me, right? Okay, great. I was just making sure. Hi, everyone. I'm sorry, my audio, my Wi-Fi is going a little out, so hopefully it should be fine and the presentation will go smoothly. As Mangshi said, I'm one of the co-founders of CHASM, Community Healing through Activism and Strategic Mobilization. And what I really want to talk to you today, Joy and Candace did a fantastic job of talking about violence prevention overall in the CHW field. And I'm sorry, I think I'm talking really fast. I'm going to slow it down. What we're going to talk about in CHASM is the policy that was passed through American Public Health Association Community Health Worker Section, a strategy to address systemic racism and violence as public health priorities, training and supporting community health workers to advance equity and violence prevention. Before we start, I wanted to give a little bit of background about myself, my lived experience in violence. So this topic is very near to me. I myself went through violence at a young age. And then as I grew up, I was in several DV relationships. And during that time, I had to figure out how to empower myself and my own children during that time. Sorry, everyone. I have my daughter with me and she just like woke up. So just give me a second. So she was just born like a month ago. So she like woke up like unexpectedly. So I apologize about that. But I was going through violence in these relationships and I had to figure out a way to get out of it. What I did was I empowered myself through school and in finding the tools as a master's in health administration student, as a doctoral student, I was able to then empower my communities and community health workers. And so much of our training is around violence prevention, and I'll go into that more in North Carolina. And then we also look at systemic racism that CHWs face in healthcare systems, which is also a form of violence. Thank you. You can go to the next slide. So the policy was a participatory process. We started in January 2021. It took about 2 years to get this passed. We initially started the policy as a late breaker and it didn't get passed. But as we continued, we got it passed in November 2023. And what I want to emphasize was how participatory this process was. I'm sorry, I'm going to go slow again. I know I'm talking a little fast. About more than half of the co-authors who wrote this policy, co-authored this policy, were community health workers. The lead community health workers, the principal authors, myself and Abdullah, are CHWs. I've been trained in violence prevention from a CBO, which is, yes, thank you for adding that, Darrell, which is a community-based organization. And Durrell was also very much supportive of the work and the policy. He was there advocating for it where it got passed at the governing council meeting. So appreciate all your work, Durrell, as well. It was led by CHWs using a participatory process. We had pre and post surveys collecting feedback on how the co-design was going, 30 plus CHW leaders and allies across the country. I also want to give out a shout out to Dr. Noelle Wiggins, who is very much influential in this policy. She was one of our advisors, and she's also one of the advisors and I believe co-authors on the CDC Lit review that came out and the work that Joy and Candace also shared. So again, I want to touch on this because this is really important. Oftentimes in systems, we see that legislators and policymakers work on their own and they don't take into consideration CHWs or those voices, the policies that they're writing for the people they're writing them for, they're not included. And so this form of equity is really important because again, it's a form of violence within our system of indirect violence when we don't include the voices of our communities who CHWs represent. Thank you. You can go to the next slide. So again, I really want to give out a shout out to all the authors. We had 7 key authors, contributors, endorsements. Our contributors also included Angie Kuzma. She is the policy manager at NACHWA. Denise Octavia Smith has been extremely supportive. We had a press release that came out on the policy and we'll share that with you. And then you'll see a number of other contributors as well. Some of them include Maria Limas, who's, as you all know, very influential in the violence prevention field. We had co-authors from PIH US, as well as a number of other co-authors who are known in the equity field and the violence prevention field. Also want to give a special acknowledgement to Betsy Rodriguez. Again, she's also from the CDC, and Rafael Way as well. And our APHA endorsements included maternal child health, public health social work section, oral health section, family violence prevention caucus, women's caucus, men's caucus, and law section. Our external endorsements, and this is prior to the policy being passed. We knew this was a policy that you'd use some very direct kind of language that oftentimes stakeholders, and due to the systemic historical history we have of oppression in our country, they may not have been as comfortable endorsing it, but these were the organizations that endorsed it. CHASM, which we were helping with that anyhow, so we endorsed it. North Carolina Area Health Education Center, North Carolina CHW Association, Honey Estrada, who's the president of that, also one of the contributors. Partners in Health, Common Indicators Project, Dr. Noelle Wiggins' team, and of course the University of Wisconsin Population Health Institute, who was also very supportive in getting this passed. You can go to the next slide. Thank you. So I want to go into how we came to the rationale of passing, or the importance of this policy. So we decided, we talked about, some of the policies that have been passed, and Jarrell and Lisa Renee, Holderby Fox, as well as others, passed a number of policies. Ashley Winterstorm, I think one of the first ones was the definition of CHWs, right? That was a big, that was passed and it got coded. They were then recognized in the Bureau of Labor. So that was a huge accomplishment for the APHA CHW section. There were also policies passed on trainings that CHWs carried out. What we wanted to do is we wanted to respond to a policy where there was underlying issues in our society that was affecting overall health outcomes and social determinants of health. When we saw the policy during George Floyd on racism as a public health issue, racism and public health crisis that got passed, we felt there wasn't a comprehensive approach of a workforce addressing it. And I'll go into that more. So our first overview we said that systemic racism and violence have been widely acknowledged as public health emergencies. However, we currently lack comprehensive strategies that address the underlying causes of these public health threats. Number two, CHWs are well suited and well placed to address these underlying causes and reduce violence and racism. Number three, to make an optimum contribution to addressing racism and violence, CHWs need to be trained, supported, and provided more opportunities through program development. You can go to the next slide. So this is the policy that was passed, and I believe Mangshi has the link that she'll put in. Again, this was policy statement 20227, a strategy to address racism and violence as public health priorities, community health workers advancing racial equity and violence prevention. The crux of it, and this was also in this CDC lit review that was done, that was led by Colleen Barbero, that you saw Candace talk about, AJPH published. It also this policy crosswalks with the socio-ecological model. So what we're saying is community health workers can address violence, also systemic racism, all the way from the individual to the community, to the organizational, and to the policy and systems level. And actually, when we were writing this policy, we had the different CHWs split up into these different groups and identify how they were working in violence prevention or systemic racism in each of these levels within the socio-ecological model. And what was found as we were developing this is that CHWs were extremely agile in the work that they did and comprehensive in the work that they did across these many levels, and one also connected to the other in the work that they do. Thank you, Jarrell, for including that. I really appreciate that. Thank you. So Jarrell just put in some other policies as well, which is really important if you all want to look at that as well. So what we also did was we were responding to two other policies. The first policy was a late breaker, as some of you may be aware, especially those of you in the APHA CHW section. It was racism as a public health crisis that got passed in October 24th, 2020. And so that was actually not a late breaker. The other one was a late breaker, which was violence as a public health issue that got passed November 13th, 2018. We felt that there wasn't a comprehensive approach to address either of these policies. There are siloed approaches throughout the country. One of the programs we talk about is Cure Violence, and there are some other programs as well. And then when it comes to addressing racial inequities, we felt there wasn't a comprehensive workforce or approach to address this. And that's when we decided that community health workers are very much effective to address both of these. And a couple of reasons, and the most driving reason is that community health workers came about in response to the inequities in their own community, the violence in their own community. So by nature, they were already addressing these issues before they were even given that name. Internationally, and then during the time of slavery, during the Black Panther movement, the CHWs, the promotoras, the community health representatives have been doing this for years. 251 cities, counties, and other governmental leaders declared racism a public health crisis. And again, we identified a policy gap that CHWs can help professionals comprehensively address inequities and violence within their community. So when we first tried to get this passed, there was pushback by many of the sections. And one of the reasons is they felt, and this is historically known, that CHWs would take their own jobs and they didn't really understand the value. And so what we said in the policy is CHWs can help your organization, can help your physicians, can help your nurses, your social workers, address violence in the community, as well as equity within the healthcare system. Once we did that, the other sections very much came on board and they were understanding. So it's very important to take away that community health workers add and enhance the work of other professionals, and they're not trying to take away from that work. And so we were very strategic and making sure that that was understood. Denise Octavia Smith and the NATRA group, the policy group, they helped us develop a national press release that went out. And that went out about, I don't know, about a year ago. I think it was released. And again, there's a link there if anyone wants to look at that. A group of us also went to Capitol Hill. Again, individuals such as Darrell, Julie Smithwick, and the Envision team, Sherry, Denise, Angie Kuzma, many of us were up in the Capitol. And one of the things that we did, CHASM did with PIHUS as well as NATRA, was we talked about this policy with legislators, both on the House side and the Senate side. And just to let you all know, sometimes it seems like our work, we're being oppressed, and again, indirect violence and CHWs and the voices of CHWs. However, there are legislators that listen and they don't know the work that we're doing in the communities. And of course, community health workers are very much equipped in helping other people who aren't in those communities understand what is going on. We found out from PIHUS that after we had met with Representative Deborah Ross, she had requested a $50 million appropriation to North Carolina for CHWs. So again, this was a request that was asked to be put in, but just in that itself, a request goes a long way. So just lifting up how important it is to keep advocating on co-designing and working on these policies. Also want to point out that Lisa Renee Helderby Fox was actually on the panel as well. And it was a congressional day up in Washington, D.C. And we literally had community health workers standing up against the wall, and our allies that went there. There were hardly any seats left. So there's a great amount, as many of you know, a great amount of interest and focus on community health workers and addressing social determinants of health, as well as looking at violence prevention, especially when we met with the legislator in New York. You can go to the next slide. So this is the rationale for consideration. And again, this is a snapshot of the press release that was put out by the National CHW Association. And again, you're going to see the connection here between violence and racial inequities. So number one, racial inequities is a key root driver of poor health outcomes in communities. One of the outcomes of these inequities is disproportionate exposure to multiple forms of violence. This becomes an exacerbator for existing social insecurities. CHWs have been engaged in building health equity by addressing underlying causes and were collectively birthed out of inequities within their communities. CHWs, therefore, can work effectively with other professionals to address systemic racism and multiple forms of violence. You can go to the next slide. Thank you. Another piece that we also worked on in this policy was redefining how we look at other populations who are historically marginalized. And oftentimes we use we've heard the word minorities, which is, again, it's not, it doesn't lift up populations when we call them minorities. Or we would say, communities of color or BIPOC. And we felt that there should be a definition that goes into the condition of these communities and what they've faced in being marginalized rather than their skin color. So the term that we use in the policy is historically oppressed and other people's experience inequities, HOPIs. And what this means is historically oppressed peoples who were brought from Africa and enslaved in America, and indigenous First Nations, including descendants of those groups who trace their genealogy back to indigenous Mexicans, Aztecs, Mayans, and Incas, etc., whose land was colonized by Europeans. In addition, HOPIs include other populations experiencing inequities: women, Muslims, immigrants, LGBTQTI, and people with disabilities, etc. So again, we felt like even in the words that we speak, it's a form of marginalizing people who have been historically oppressed. And so we felt we needed to come up with a definition that would lift up their condition and their experience. You can go to the next slide. Thank you. So these are the action steps, and I apologize. This is much smaller than I thought, but there was a number of action steps that our group came up with. So APHA encourages external constituencies to take the following comprehensive actions to train, support, and measure the impact of CHWs to address systemic racism and prevent interpersonal violence among Hopi communities most affected by inequities. And again, this is in the policy. So the link that Mangshi put in, if you click on that, you'll be able to see what those action steps are in detail. What we did is we just bolded some key ones. So one of the key ones is make funding available to community-based organizations, and also look at experience training CHWs using effective strategies such as popular education to provide training that builds CHW skills to address systemic racism and violence as public health priorities. Also, recruit, hire, and retain CHWs to create programs that support CHWs to play a wide range of roles, including roles focused on addressing violence and promoting health equity across all levels of the socioecological model. And I just want to emphasize that CHWs are very much equipped to address policy, to work within organizational systems, to do research, to do evaluation. And this goes back to the C3 roles that Candace and Joy talked about. Make funding available to researchers and evaluators with experience working as or with CHWs and using community-based and community-engaged strategies to assess the impact of CHWs and to develop and conduct studies that use consistent measures. Provide funding that allows sufficient time for program and evaluation planning that is sustainable over the long term. And then collect consistent data about both the process and outcomes of CHW programs, such as those developed by CHW Common Indicators Project with funding from the CDC. So again, I want to emphasize process is really important. We often look at outcome measures, healthcare systems look at outcome measures, and we have to also look at the short-term outcomes that CHWs are able to, they're able to deliver on really quickly. And we need to be able to also look at that as well. Those process outcomes are really important. You can go to the next slide. So these are other steps as well. APHA calls on legislators to pass legislation providing funding to state health departments to take actions consistent with the above priorities. And this also includes employers to endorse CHW training in interpersonal violence and systemic racism, stated in this policy proposal, not only endorse the trainings, but then be able to employ the CHWs. APHA calls on foundations with and other funders to take actions consistent with the above priorities, provide funding for organizations for Hopis with experience training, hiring, retaining, and conducting research and evaluation with and about CHWs. This funding should strengthen the ability of the CHW workforce to address structural racism and violence, again, as root causes of health inequities. And lastly, APHA calls on colleges and universities that train other public health professionals to also understand the importance of community health workers. Again, there's interpersonal violence going on in our healthcare systems when public health professionals don't understand the roles of CHWs, the importance of CHWs, and most importantly, how they're effective workforce. They can be their eyes and ears to understand what the community is going through when it comes to violence prevention. You can go to the next slide. Thank you. This is some of the work that we've been doing, implementation of the training models. And again, this policy is for all of you to use as a foundation for the trainings that you're doing in violence prevention, for the trainings that you're doing in systemic racism. It should support the trainings you're doing. We also refer to it, and CDC Lit Review was very much a foundation in the policy as well that we used. Another foundational piece was community-based public health response to violence, which originated in the Cape Fear region, and now is being implemented in Buncombe. And the origin of the curriculum is from Oregon. And I want to give a shout out to Dr. Noelle Wiggins, who was a mentor for Abdullah, who unfortunately cannot be here today because he's actually doing a training right now in Tennessee for CHWs and violence prevention. Again, CHWs and violence prevention have been trained in Buncombe and Cape Fear regions so far. 100 CHWs violence prevention will be trained by February 2024. And then CHWs as equity advocates, we actually had a pilot of that training at APHA, the pre-APHA summit, where we also had the National CHW Association attend. Angie was one of the co-designers and trainers there, as well as Dr. Noel Wiggins, myself, Abdullah Pede, and Sergio. And it helped to inform the RWJF HPRS dissertation work, which looks at inequities that CHWs face within the systems and how to uplift their voices within systems. We're also doing trainings in North Carolina, looking at advanced medical home CHW health equity training, supervisor training, popular education training, CHWs as evaluators. And we also have a health equity assessment tool that's been developed. We've also trained federally qualified healthcare centers and doing a train the trainers for the supervisor training. And then lastly, we work with Julie Smithwick and Mike Young to develop the training for CHWs in health equity for South Carolina and North Carolina, and this was funded by Johnson & Johnson. So again, just getting back to the point that this policy is very much a policy that is for on the grounds work. It's not a theoretical policy that sits on a shelf. It should be very much applied. And what we want to lift up here is the importance of implementing trainings for community health workers, funding community-based organizations where community health workers are partnered in the central voice, and making these interventions something that's transformative within the community, and then also partnered with healthcare systems, and not only having equity within healthcare systems by looking at systemic racism, but also looking at those inequities within our communities and developing those equitable partnerships between the two. You can go to the next slide. Thank you. Thank you so much, everyone, for your time.
No, thank you, Ramana, for that presentation and really elevating CHW voices when it comes to training. I really appreciate that as a CHW myself too. So thank you again, once again, Ramana, for your presentation. So next up, we will be hearing from our final presenter, Jackie Lowe, who is a CHW and working in violence prevention. And she is also one of our Envision CHW council members. So really glad to have her come on and present for us about her work in violence prevention. So Jackie, thank you for joining us today.
Thank you for the invitation, and I'm looking forward to sharing with you all about the work that we do through my nonprofit. First thing I am going to do is share in the chat information about the Micronesian Islander community, the organization that I work for. I have our webpage and our 2 social medias, whether it's on Facebook and Instagram. You are more than welcome to follow along on the work that we do. So hi everybody, my name is Jackie Lee. I'm Executive Director and a community health worker, specifically working within the Micronesian community here in Oregon. We also provide support and services back home on our islands, to the islands of Chuuk, Pohnpei, and the Marshall Islands. And the title of my presentation today is CHWs and Violence Prevention. Next slide. So I'm going to talk a little bit about MIC. So we are a 501c3, a nonprofit organization that's based here in Oregon. And we provide services to Micronesians and to Pacific Islanders. And initially, when we first started, we were Salem-based, and then we became more statewide. And like I mentioned earlier, we now do outreach back home on the islands. And the picture that you're looking at right there, that actually is a photo from a navigation training that we did that was specific on vision navigation services. Next slide. So our main 3 priorities is on housing, health, and workforce development / education. And our mission is to organize social justice programs that also allows us to preserve our cultures and also enhance our leadership through the unification of our diverse communities. In the picture you see there, that's actually from one of our food outreach events, and we were handing out information about COVID-19 at the time. Next slide. And many of our services, it's, like I said, a variety of different programming. Under health services, it's domestic violence, sexual assault, abuse prevention work, diabetes prevention, prenatal health care, food resources, Medicaid, Medicaid information enrollment, car seat safety, tobacco prevention, even health screenings. We also do workforce development specifically for healthcare interpreters and community health worker training. And for housing, we provided emergency rental assistance, short-term housing, as well as renters' rights workshops. Next slide. And so a little bit of background about Micronesians in general. So the Pacific Islands consists of 14 sovereign states and 11 total collectives, and they are classified by 3 ethnogeographic groupings: Melanesia, Micronesia, and Polynesia. And the group that we specifically work with are people from the Micronesian Islands. And that includes people from the Federated States of Micronesia, for example, the Chuk, Pohnpei, Yap, Koshrai, Republic of Palau, the Republic of Marshall Islands, Guam, the Northern Marianas Islands, and Kiribati. Though the majority of our community that we serve are from the Kofa Nations, and the Kofa Nations again includes the Federated States of Micronesia, Republic of Palau, and the Republic of Marshall Islands. Next slide. Okay, so a little bit of background information from the 2020 census. So it's roughly about 690,000 people who identified as Native Hawaiian or Pacific Islander, but about 900,000 who identified as NHPI in combination with another race. And then specifically among the Native Hawaiian Pacific Islander, there are roughly 620 who identified as Native Hawaiian, 212,000 who identified as Samoan, 156,000 who identified as Chamorro, 65,000 as Tongan, and about 50,000 as Fijian. And it's also interesting to note that the numbers specifically for other individuals from the other islands of Micronesia aren't listed. And that also could be in part because that data wasn't necessarily collected unless people self-identified as such. Next slide. And so a little bit of background specifically about DV-SA rates at a glance. So this specifically came from the United Nations Women Report Ending Violence Against Women. And it's estimated, and this is a huge gap, 60 to 80% of women and girls from the Pacific Islands who experience physical or sexual violence in their lifetimes. But the rates vary across states, territories, and even in cultures. And this is very alarming because it doesn't really give us an idea of how many women and girls, especially among these different regions, are impacted by DV and SA rates. Next slide. Sorry, I just realized that this slide might be a little bit smaller than expected. But then if you look at the details, like from the same report, from a UN Population Fund report, and looking specifically of intimate partner violence from Asian and the Pacific regions, it's speculated that 25% of people in Palau to even 68% in Kiribati are individuals who've been affected by physical or sexual violence by an intimate partner. And even from Kiribati to Tonga, where the rate of people who experience physical violence by a non-partner since 15 years old is anywhere between 11% and 68%. And even the same could be said for the sexual violence, where it could be 6% to 47%. But again, this tells us that these numbers are not necessarily accurate because of either lack of reporting or the ways that these are being reported to the different agencies and entities. Next slide. So the next part, I'm going to be talking a little bit about how MIC has been addressing or working towards addressing domestic violence and sexual assault. Next slide. So first, we do have a variety of community health workers who work with us, and these are individuals from the community who they themselves may have witnessed or experienced firsthand violence. In other words, they're also familiar with specific cultural customs. They also may speak the different languages from the community. Right now, MIC has a total of 8 staff, and we provide support in a total of 4 different languages. Again, because those are the communities that we primarily work with. We do have connections to other communities and organizations who can provide language support should we encounter somebody who needs specific support. And also another thing that our CHWs have is the ability to navigate safe spaces and recognizing that when it comes to working within our community, having conversations about SA and DV is not something that we openly talk about. So these are individuals who are very familiar with the implications relating to being a survivor of DV/SA, or who's still experiencing ongoing issues with SA and DV. So this includes recognizing that there's stigma that's associated with this. It also is recognizing, excuse me a second, I need to clear my throat. It also is recognizing that having these conversations is very challenging, and being able to work with community and having these difficult conversations, but again, in safe spaces. Next slide. So one thing that we've established are having culturally specific workshops. And this photo is actually from one of the workshops that we first started with. And this was actually a pre-COVID snapshot from one of our events. And at this one, we actually had trained some of our staff to be involved with a curriculum at that time that was a workshop series that was designed more for Polynesian communities, but we made it more Micronesian specific. And these workshops specifically focus on violence prevention. We had conversations within these spaces talking about what is violence, what is a healthy relationship, and what are ways that we can work together to address violence within our communities. Next slide. Then because of COVID, we had to pivot to a virtual training series. And when we did a virtual session, we did more instead of conversations and more cultural sharing. And people were invited to come to these closed Zoom meetings, and these weren't recorded or broadcast anywhere because of the sensitive natures of the conversation. And the conversation centered again on sharing information and knowledge about our cultures, as well as having conversations about how do we address violence within our community? How do we make it safer, especially for girls and also for women in general and for our families? Next slide. And so the next steps for the program, now we're starting to pursue more active engagement since we are more comfortable meeting in person, but we're still offering a hybrid approach for individuals who aren't comfortable or able to meet in person. And so we're continuing to seek funding for our ongoing work. And we've identified a new curriculum that's actually a 12-week curriculum on DV/SA prevention, but it was designed again for Polynesian families, but we will be modifying and adapting it to make it Micronesian centric. And we also have staff who will be facilitating these workshops after they are trained on that specific curriculum. So we're in the process of inviting the trainers to come and meet with us to ensure all our CHWs are trained in this curriculum, as well as key members of the community who would like to lead this curriculum. And then our staff and other members of the community who are comfortable leading the trainings will be the ones to facilitate these workshops. Next slide. And I wanted to end this with actually a quote from somebody from our community who died back in 2017. He was a major leader, a Chuukese leader named Wright Sonis. Ekis me ekis. In English, it's translated to little by little, little by little. And that's all I have for today. So thank you for your time and attention.
Thank you to all of the presenters. I think violence prevention is something that we don't talk about much in the CHW work. So I am really glad to have had this time to highlight violence prevention work. We will have a Q&A section. So can I have you all wait for a little bit, and then we will go into our Q&A section in a bit. While the polls are going, we could start with our Q&A section. So if I could have you all, for folks who want to ask a question, if I could have you use the hand emoji, that would be great. So I know Clifford has been having his hands up for a while now, so I'm going to call on him to ask a question.
Yes, thank you so much. My name is Clifford Ryan, and I am a CHW worker here in the city of Syracuse. And I do violence interruption here in the city of Syracuse through my organization called Our Generation Against Violence, and the acronym is OGs Against Violence. To date, I have stopped 44 shootings, 100 stabbings, and more than 1,000 fights in our community. And while I was out doing CHW work for Syracuse Cares organization here in Syracuse, I had to stop a few violent situations from happening on sites that we were at. My question is pertaining to some of the other programs. Would we be able to get some of that information pertaining to some of the other organizations that do similar work for our information distribution here in the city of Syracuse?
So Clifford, if I'm correct, are you looking to find ways to connect with other CHW networks that are also doing violence prevention work?
Yes, yes.
So do we have anyone? Oh, yep, you could go. Yeah, so do we have anyone on here that could answer that call, or that does, or any CHWs here in here that does do violence prevention work that would like to connect with Clifford, or even our speakers, if you have any resources or other partners that you all could connect Clifford with?
So I'll jump in, and other CHWs on the line, please also feel free to dovetail. I do think that acknowledging the exposure to risk and also the extreme work that you're doing in the field is spectacular, Clifford. And so we personally at the CDC have been trying to collect different stories and uplift the work that's happening in the communities, and also discuss some of the different challenges that are happening and providing kind of different resources when we're thinking about personal safety for the CHWs, but also how this intersects to both resilience within the communities. So I definitely can email you some of the different resources that we've been attempting to collect, but also believe that there's collective wisdom on the call. And so know that a lot of people on the call also might have some experiences in regards to dealing with some of the different challenges that happen while trying to support the community.
Appreciate it.
Thanks, Brother Clifford, for sharing. I mean, Darrell Fox, I'm a CHW in Atlanta, but my first 50 years was up in New England, in Boston, and I work with a statewide youth gun violence prevention project currently. That's out of the Massachusetts Department of Public Health. But I also want to, you're in Syracuse, and I know that the Rochester has a CHW association. I don't know how far that is from you. I know upstate is large and wide, but I wonder if you're yeah. So I wonder if you're connected to some of the networks that are in New York. I know Buffalo has a network, so I saw your information. I'll get you offline and hit you up with a couple of resources. But I think based upon the shout out to Ramana, the CDC presenters, because I think there's going to be a lot of work together to kind of connect this violence prevention work with CHWs, because in some areas, like in New England, the street workers is the term they use, and there's not as many connections with CHWs doing violence prevention. So we're working on that. But I think some of the efforts of the CDC group, working with Deloitte, others, there's going to be a lot of people coming together in this country. I know somebody from Hobby might be here as well, which is a national organization that also has been a connector. They do a national conference every year. I think The one coming up might be back up here and back up here. I'm not in Boston anymore, but in Boston. So I know we don't have a lot of time, but I'll connect with you offline, Brother Clifford. Thank you.
I will also interject. This is a perfect opportunity and a place on the My Envision community platform that we launched just a month ago to connect these type of resources and directly with other CHWs. You can find them in your area or people doing comparable work in different parts of the country. And it was one of the main reasons we put the platform up there is for all of you to have a place to connect together directly, offline and outside of the webinars and the meetings that we have. So if you haven't already, check out myenvision.org or go through our website and join if you haven't, and become part of the community and continue to share the resources like Darrell has mentioned and people are asking for here. Thanks.
Thank you, John, for that. Do we have any questions, additional questions for our presenters, or just even our participants on here as well too? Or do we have, or like, do the presenters have any questions for our participants as well? Yeah, because I just want to highlight that these are the folks on this call, like the presenters and even attendees, they are the ones doing this type of work. Like they are the pioneers of the work. And I just want to let everyone know that these are the perfect people to be asking questions when it comes to CHW and violence prevention work. These are the experts, subject matter experts who've been doing this for a while. So please take this time to ask questions or, comments, because we still have a good 10 minutes, about 10 minutes to give Q&A for everyone.
Excuse me, I do have one question.
Yep.
Can you hear me?
Go ahead and, yep, you can go ahead and ask.
I do appreciate, which is kind of a question, kind of a statement. I do appreciate you guys is also acknowledging that violence and abuse doesn't have to be physical, and that the mental and emotional turmoil can be just as detrimental as the physical. So do you guys have any literature or resources that touches on that in depth?
Was that Tristan that spoke? Did I get that name right?
Well, my name is Antoine, but I'm using one of my coworkers' tablet because my computer is down. But yes, I'm Antoine. It's lovely to meet you.
Wonderful to meet you, Antoine. And your voice didn't sound like a Tristan. So I was just
Oh my God. I would hope not.
You're good. Thank you for clarifying. So in our training, we do look at that. We look at DV and again, domestic violence. I've lived experience of domestic violence, and you're absolutely right. It includes mental, psychological abuse that can sometimes even be even more damaging than the physical abuse, and gaslighting and so many other things that happen to women and can happen to men as well. And so we don't have literature that we've published on it per se, but in our training, we do talk about that and interventions to address that type of violence that takes form in our communities, especially, when it comes to domestic violence with them. So thank you very much for lifting that up. It's very important to understand that violence is not just physical. And even when it comes to interpersonal violence within the system, it's not only physical, it's also mental abuse as well that takes place in psychological abuse.
Yes, I definitely learn from experience. So I always want to open that door because it's hard to talk about, with the stigmas that come with mental illness and emotional instability. So I just wanted to be the first person to open that door, that if it needs to be discussed or if there are questions, be comfortable. And I will start it off. So that's all. Thank you.
Thank you again, Envision, for kind of creating this container where we all can talk about kind of how CHWs are operating in the space of violence prevention. I would be curious on the line if anyone had any comments or thoughts about other information that you'd want people to know about violence prevention or potential supports that would help you in regards to doing the
Was the last part of the question cut off? I didn't even hear what the last part of the question was.
Oh, thank you, Jackie. Sorry about that, everyone. I was saying I would be very curious to hear on the call what other people's experiences are in regards to if there's any other information requested or what would be helpful when doing the work of violence prevention as a CHW.
If I may, I found that doing the violence interruption work that I do in the community, getting the proper training and knowing how to address dealing with violent situations is very, very important because we deal with a lot of mental health aspects of it as well. So getting the proper training and knowing how to address, violent situations is very, very important.
Hi, my name is Sheree Wallace. I live in Madison, Wisconsin, and I am on a grant, part of the violence prevention to stabilize communities. And what we sometimes fail to realize that not only is the person that's a victim is harmed, but the whole community is harmed. So when there's a shooting or something of that effect, I go into communities, have community table talks, ask the residents of that community, what could we do different to make the community safe? I was trained to be a community safety worker, and it's a program that is led by this man named Anthony Cooper. It's called Focus Interruption. So I was trained to be a community safety worker, and in that you really see, and I'm a community health worker, but being a community safety worker, that put me in the midst of a lot of things, like when the police is called, if the person choose to get resources from the community safety worker, and we are called on the crime scene or on the scene where there's low-level crime, the person can choose to work with us and they will not get a ticket, like if it's a domestic violence or a battery, or it all depends on what the situation is. Only low-level crimes, if they volunteer to work with us and we provide them with the wraparound services, they will not get a ticket. So my main focus is to build leadership among people that's in that community affected by violence. And I do that over table talk. I bring city providers in, I bring in the police department, I bring everybody to the table, aldermen, everybody that can make a difference and help change in the community.
Sheree.
Yes, I'm through.
Okay. I have a question for you.
Mm-hmm.
You said it was low-level crime. So
Yeah.
what do you consider or what is considered a low-level crime?
So low-level crimes is probably a disorderly conduct, a disorderly conduct situation. Low-level crimes could be a teenager and his mom having a dispute, you know. So we'll go into there. If the mom agrees to work with us, we would probably do an assessment of the mom and the child. And most of the times we find out the mom is struggling. And most people don't realize when kids know when their parents are struggling, and it affects them. So we offer resources to the parents, as far as maybe they need a food card, or maybe they need a bus pass, or something in that effect, or maybe they need some more housing information, or behind on their rent and need some help. So that's what we'll provide. Then we'll reach out to the child to see what the child's needs are. And maybe he want to get involved in some kind of community activity, you know. Maybe he want a job but need help obtaining his birth certificate. That's the kind of things that we do.
How long do you usually work? Is there like a certain limit that you?
Okay, you know, when you're working with a client, and when you pull off a Band-Aid, then you open that wound and you can solve one thing, and then they feel comfortable with you and trust you. So we probably help them with that situation. But now they found some people or a community health worker they can trust. And so they encounter into another problem and they reach out to us. So we don't just close cases, because we always call in once a month and check on everybody that we done had contact with.
Thank you, Sheree.
You're welcome.
I know we had like really good conversations, but unfortunately I'm gonna have to cut it off because we are on time and we're gonna wrap it up. But I just want to thank all of the presenters one more time, and I do want to thank the participants as well too, attending the webinar and just creating great conversations with this type of work that we are doing here at CHWs. And I'm really appreciative of all your time that you have spent, joining us in this webinar. So thank you so much, everyone, and I hope to see you all again next month.